Hello, I'm Jan Leifman.
I'm Gayatri from Menon.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Theodoros Teknos. Dr. Teknos is the president and scientific director of the Seidman Cancer Center. He's also the Jane and Lee Seidman Chair of Cancer Innovation at the University Hospitals Cleveland Medical Center, and also the deputy director of the Case Comprehensive Cancer Center.
In today's presentation, Dr. Teknos discusses biological and novel therapies in cases of HPV in head and neck cancers.
Did you know that Dr. Teknos is an internationally recognized leader, physician, and researcher in head and neck cancer? He's also a global authority in developing business plans for cancer-related palliative care. He was awarded 2 patents in lipid-based nanoparticle delivery of MIR 107 for head and neck cancer, and in system and method of otoscopy image analysis to diagnose ear pathologies.
He is truly a global leader in the field of oncology.
So let's tune in and learn from this internationally renowned global pioneer.
Thank you very much for that very kind introduction, and it really is a privilege to be here with all of you. And I'd like to thank MedNews Week for the opportunity to address this audience. The topic I'm going to talk about today is HPV-related head and neck malignancies, and specifically talk about the biology of this disease and outline some novel therapeutics, which I think you'll find very interesting and probably surprising. So first of all, what I want to start out by identifying is a little bit of the anatomy. So HPV-related head and neck malignancies occur in the oropharynx. So for those of you who aren't familiar with head and neck anatomy, the oropharynx is at the base of the tongue and the tonsil. And if you look at this schema here in a sagittal view, it really is from the soft palate down to the hyoid bone of the person's neck. But the predominant areas where HPV-related malignancies occur, again, are at the base of the tongue and the tonsil. And that's where the lymphoid tissue lives of the palatine tonsil and lingual tonsils. And for a reason that, again, is yet to be determined, the basal cells of the tonsillar crypts are where HPV tends to infect the head and neck region. Now, looking with the scope, what I'd like to point out to you here is this is a scope looking from above. The larynx is down here with the vocal cords. This is what normal mucosa should look like. And we're looking at the base of tongue. And you see a very large tumor here that is encompassing the right side of this patient's base of tongue and progressing over to the left side as well. So that is a primary base of tongue malignancy, which up until, as I'll explain, a few decades ago was primarily caused by smoking and drinking. But as we know now, HPV plays a major role. So the etiology of most head and neck cancers were mostly environmental, in the fact that an overwhelming percentage of people smoked and abused alcohol. This is a classic picture here of a gentleman who would be a likely candidate to develop a head and neck malignancy. Other etiologic agents were patients who are immunosuppressed, whether it be congenital immunosuppression, immunosuppression related to HIV, or transplantation. All those patients are at higher risk for head and neck cancer. Some vitamin deficiencies, especially vitamin B12 in the hypopharyngeal regions of head and neck cancers. And individuals with poor oral hygiene, poor nutrition, a chronic syphilitic infection, and or previous radiation therapy to the head and neck. But really, beginning in the 1990s, HPV was identified as a etiologic factor in head and neck cancer, particularly, as I said, the base of tongue and palatine tonsils. And this caused a major shift in the disease, as I'll explain to you in a moment. So our classic head and neck cancer patient is somebody who was older, who was male, who was a smoker, a drinker, was malnourished, tended to be edentulous, come from a lower socioeconomic status. And when you looked at their tumors under the microscope, it was a keratinizing squamous cell carcinoma. The survival for these patients, and this is for tongue-based cancer, and we look at survival at 5 years. You know, the survival in stage 1 and 2 malignancies of the base of tongue. And this study was published in 2003, so it predated really when we started to see HPV positive patients. But stage 1 and 2 tumors of the base of tongue had about a 70% survival rate. And just to be a little bit more clear, those are tumors that had not yet spread to lymph nodes in the neck. So those were the stage 1 and 2 tumors. Those that were larger tumors and tended to extend to the lymph nodes in the neck had survival rates, as you can see here, dismally in the 30 to 40% range at 5 years. So those results were clearly unacceptable, and not to mention that the surgeries to remove these tumors caused a lot of morbidity. So when I was at the University of Michigan, my colleagues and I designed a study which looked at these patients to see if we can treat them non-surgically in certain instances. So this study was conducted in 1999, and not to bore you with the details of it, but in essence, we gave patients induction chemotherapy, which happened to be cisplatin and or 5-FU, or carboplatin and 5-FU. And those patients who responded partially, that is the tumor decreased in size by 50% or more, went on to undergo concurrent chemoradiation therapy. Those that didn't respond went immediately to salvage surgery, and then we completed the therapy. But what was unique about this study, and this elucidated a lot of the etiologic agents and predictors of response, was the fact that we had tumor specimen that we could do research on, and also had all the demographic data for these patients. So what this study showed is some remarkable results. What you can see here, and this is a scope again, prior to the definitive therapy with chemo and radiation, a large tumor which extended from the lateral pharyngeal wall, involved nearly 2/3 of the tongue base, went into the vallecula. You can see the larynx here. And then after concurrent chemoradiation therapy, you see this tumor completely melt away, and you see normal mucosa left behind. Now, I will point out that what you see in the vallecula here, or just in front of the voice box and coming behind the voice box, and for those of you anatomists here are the vocal cords. This shows that while that tumor went away, it was replaced by scar tissue, and this is saliva that's pooling in that area. So these folks did have, as I'll explain in a minute, some difficulty swallowing, but their tumors melted away, and they never required surgery at all, which was unheard of up until that time. Here's another example. This is the tumor that I showed you in the beginning. Very large exophytic tumor, and you can see it completely melts away after concurrent chemoradiation therapy. But again, I'll point out that there's a fair amount of saliva that could be difficulty and cause some swallowing difficulties for the patient. But no surgery was required. And this really was a landmark study in the treatment of these patients. What was unique, though, as I said, is we had the tumors for these patients. So we could do some translational studies and look at the demographics of these patients. So this study was published in the Journal of Clinical Oncology in 2008. And what you can see and what we identified is that patients who stained positive for P16, which is very clearly shown here, P16 positive staining versus P16 negative staining. And P16 was related to HPV positivity. So when a patient is HPV positive, there's overexpression of P16 in their tumors. So it's a very easy test, and it's a very accurate test for HPV positivity. So what this slide shows is overall survival, and I'll remind you, these were all stage 3 and 4 patients. And you remember early, I told you that those patients survived only 30 to 40% of the time. But what we saw in this overall survivor probability at 5 years was that nearly 60% of our patients survived. And when you look at, who survived, the males survived more commonly than the females. But what was really striking to us is that those who had never smoked or survived the best, those who were smokers in the past were kind of in between 75% survival rate, and the current smokers or recent smokers had the worst survival rate. And you can see that nearly overlapped with the HPV positivity in the patients. So we determined that those patients who were P16 positive tended to be patients who never smoked or who had smoked in the past. It was nearly mirror image curves. And then the HPV positive patients tended to be those who were current smokers. And that bore out in our analysis. So this was a novel finding that HPV found in the tumor actually conferred a survival advantage. This resulted in another study, a national study that was very similarly designed to our study at the University of Michigan. And these results were even more remarkable. HPV positive tumors survived 95% of the time at 2 years, whereas only 62% of those that were HPV negative survived at 2 years. And that's an incredibly striking difference of nearly 30% just based on that single biomarker. Even more impressive was that HPV positive tumors were 64% less likely to die and 63% more likely to have progression-free survival. So again, it sort of validated the earlier smaller study that was completed. The most recent survival statistics now, which I think are very important for the audience to remember, is that HPV positive patients with HPV positive head and neck malignancies who were non-smokers have an incredibly high survival rate, 93% for very large tumors. HPV positive patients who smoked actually had about a 75% survival rate, and HPV negative patients or who were smokers basically had a very poor survival rate at about 30%. I think, one thing that's that always helps, validate and stick in people's minds with this is maybe some celebrities who've had these types of malignancies. So, if you're fans of baseball, there was a baseball player recently who was diagnosed with an HPV positive tumor who was a non-smoker, and he survived and did quite well and returned back to playing. HPV positive smokers, 75%, that's Michael Douglas. Michael Douglas admitted that he had an HPV positive tumor and he was a smoker, and he was quoted a 75% survival rate. So I think Michael Douglas fits into this category. And then finally, an HPV negative tumor in a smoker is actually Larry Hagman, who played J.R. Ewing. If you remember the show Dallas, he was a smoker who developed a base tongue malignancy and succumbed to his disease. So it's sort of a picture to keep in your mind of the types of individuals who develop these cancers and their survival rates. Now, this is a study that looked at 266 patients with these types of tumors. And what it showed was that the most important predictor of survival, this is a recursive partitioning analysis. And what this shows is that the most important predictor of survival is whether a patient is HPV positive in their tumor or HPV negative. The next most important predictor when patients are treated with definitive chemoradiation is how much they smoked. So if they had no smoking history or less than 10 pack years, their survival rate was outstanding. They were considered low risk. And you can see here, those are the 93% survival patients. Those patients who had greater than 10 pack years of smoking and had small lymph nodes in their neck, they were still considered low risk. And they had excellent survival rate. But those who ended up having big lumps in their neck or big lymphadenopathy and who had larger tumors kind of fell into this intermediate risk. So really the smoking rate, the size of the tumor, and the lymph nodes made the predictors fall out in this category. As I mentioned before, though, there are long-term complications to this treatment. One, an example of this is a lot of patients are G-tube dependent, meaning they have a very difficult time swallowing. As I showed you, the anatomy changes and people can aspirate. So they are dependent on G-tubes. And you can see that in a European, American as well study, the Europeans found a 30% rate of G-tube dependence at 1 year. At the University of Chicago, Dr. Everett Vokes quoted a 14% rate of G-tube dependence at a year. And at Oregon Health Sciences University, there was about a 31% rate of G-tube dependence. So these treatments are not without their complications. Osteoradionecrosis can occur, and at a rate of about 5%, which is radiation damage to the jaw, which can cause significant problems. And then the chemotherapy can cause neuropathy in about 14% of cases. That's peripheral neuropathy, and can cause hearing loss in up to about 25% of patients. Another famous patient that I want to share with you with regards to complications is Val Kilmer. Val Kilmer had a HPV-related malignancy, and the complications of his treatment have been plain for the world to see. He's tracheotomy tube dependent. He can't really swallow, and those are complications from his chemo and radiation therapy. So really what has been defined as a new cancer, HPV-related head and neck squamous cell carcinoma, is a distinct clinical entity, different from the typical head and neck malignancies that you've experienced in the past. It's in the oropharynx, primarily the palatine and lingual tonsils. It is poorly differentiated under the microscope, and a moniker that's used is that it's basaloid in nature. It tends to have a small primary tumor and large neck metastases. So if you see a patient who has never smoked, but has developed a neck mass, and there isn't any symptoms related to a primary tumor, be sure to think about HPV-related malignancies, because it's becoming, as I'll show you, exceedingly common. Typically, the primary isn't known. Now, the good news is HPV, when it does cause malignancy, has a much lower rate of death. So the survival is much, much higher. And as you can see here, the hazard ratio is far below 1, and typically somewhere around 60% less likely for the patient to pass away from their disease if HPV is found in the tumor. And this is a number of studies you can see with thousands of patients who show similar results, that the hazard ratio and the likelihood of death is much lower in patients with HPV-related disease. There's also different risk profiles for these patients. So when a large study, which is undertaken by Dr. Maury Gillison, looked at tobacco use, alcohol use, oral health as measured by the number of teeth that have been lost, oral sexual partners, as well as marijuana use. And what you can see in HPV positive tumors, tobacco use tends not to be predictive of malignancy. Alcohol use is also not a significant predictor. Neither is poor oral dentition. However, the larger number of oral sex partners a patient has, and the more marijuana that they've smoked throughout the course of their lifetime, are closely related to their likelihood of developing this type of malignancy. On the flip side, patients who are HPV negative, or your typical smoker drinkers, have the expected amount of correlation with cancer rates going up according to the number of pack years smoked, cancer rates going up according to the number of drinks per drink years, and also cancer going up with a significant increase in the amount of loss of teeth or poor oral hygiene. The others do not reach statistical significance. So very distinct risk profiles as well in this disease. So here's our, revisiting again, our classic head and neck patient. They tend to be older, male, smokers, drinkers, malnourished. You're sort of your typical patient that in the States we would see at the VA, or we would see, at more geriatric locations. But the new patient that develops oropharyngeal cancer is very young in age. Typically, we can see patients as young as in their early 40s. They are typically male on a 3-to-1 scale or 3-to-1 ratio compared to women. They tend to come from higher socioeconomic levels. Their risk factor really is their sexual activity. Many of them tend to be non-smokers, non-drinkers, and they have a very different pathology. And just to sort of talk a little bit about the epidemiology, most of these patients are infected with HPV in their college years, from 18 to 26. The vast majority of these infections are cleared by 2 years. However, for that 2-year period of time, those patients are infectious and can pass that disease along, or that infection along. Then there are a subset of patients, however, where the disease lays dormant and it can intercalate into the DNA and cause malignancy, but it tends to be 30, 40, 50 years later. What triggers that, I will go into in a little bit, but that's the natural sort of lifespan of an infection. So how prevalent is this? I think it's really important to answer that question. And right now, there's no gold standard for detecting this. Really, oral rinses with something as simple as mouthwash is the most accepted approach. And then identifying the HPV DNA in the saliva is the most accurate way to determine if someone is carrying this disease around. So how common is this? And this shows the percentage of patients who are carrying oncogenic HPV-16 in their oral cavity. So you can see that in the college age education, and this was actually done at a college campus outside of the recreational activity in completely asymptomatic patients. So 8.1%, or 1 out of every 12 college students, had oncogenic HPV in their saliva. The adult population has similar numbers, between 5 to 10%. The hospital-aged population, or patients in the hospital, were up to 18%. Patients with HIV were up to 35%. Women who had genital HPV had higher rates, almost twice the average, and spouses of patients with HPV-related malignancies were up to about 25%. So this is not an uncommon disease. The other thing that's important to note is that when you look at men and women, there seems to be a peak at around 6 partners, whether it's any type of sexual partner versus an oral sexual partner or vaginal sex partners. When you reach about 6, that's where the rate tends to go up pretty significantly with regards to contracting the virus. Well, my apologies for that. What's very interesting also is to look at the prevalence of this disease, and we can look at men and women, but these are on the one axis here is the smoking rate. This axis shows the number of lifetime partners, and it shows in the upper panels the prevalence by age group, and the bottom panels the number of infected men in each of these age groups. So if you do all the math, there's about 8 million men infected between the ages of 15 and 69 just in the United States alone. And as you can see, the highest bars are in the never smokers with a large number of partners. As you can see, in ages 60 to 69, you see fewer, but really this age group of 40 to 59 years old is where you see a lot of this. And you may say, what happened there? And really, these are the this is the generation that kind of grew up in the 60s, and that loosening of social mores in the 60s is really why that population has the highest rate. And the lower age groups actually are going to be even more of a concern as the years pass. Women have a much lower rate, but what's interesting in women is that the prevalence is higher in both a large number of partners and current smokers. So that's a little bit of a different demographic, but there's only about 2 million women infected in these age groups. So a much lower rate, and that's thought to be because they, number one, are likely to be more vaccinated with HPV vaccines, and number two, having achieved some exposure to HPV through sexual contact, cause them to be immune to it in their oropharynx. So how dangerous is it to have HPV infection in your saliva? Well, when you look at the likelihood of developing head and neck malignancy, let me put it in perspective. So if someone is an alcoholic, heavy drinker, they have about a 4-fold increase of developing head and neck cancer. If you're a heavy smoker, you have a 10-fold higher increase than someone who isn't a heavy smoker to develop a head and neck cancer. But if you both drink and smoke, you have about a 40-fold increase. If not only drink and smoke, but if you're an alcoholic and you smoke heavily, you have about a 40-fold increase or adjusted risk compared to somebody who does neither. Well, you can see here that if you have an HPV positive infection, you're 53 times to 63 times more likely to develop a head and neck malignancy than someone who doesn't have this infection. So it is as dangerous as being a heavy smoker and heavy drinker. And there's a bimodal distribution. So most of these infections occur, as I said, kind of the late teen years and peak at 26. And then there's a second peak that occurs at ages 55 to 60. So you can see that, this is likely at first exposure, but at both of these times. Now, what's interesting is the rate of malignancy really starts, as I mentioned before, in the 40s and continues to go up, and as I'll show you, almost exponentially as people age, as their immune systems weaken. This is a graphic that shows that this is men by decades of life, and you can see that the younger decades are down here, but as people age, the rate here shows that there's a 30 per 100,000 man years risk of malignancy in individuals the longer they live. So it is likely that latent HPV DNA just intercalates into the DNA, and the longer patients live, the less their immunity can root out these malignancies early, the more likely they are to develop an HPV-related malignancy. Women tend to be a little bit protected over time, but again, they are at risk. So when you look at how this is increasing, the Swedes actually have a tumor registry and a cancer registry, and they bank all the tumors in the country. And what you can see here, in the decade of the 70s, only 23%, and this was done retrospectively, tested positive for HPV. In the 80s, it went up to 28%, but there was an enormous jump in the 1990s, up to 57%. Between the year 2000 and 2002, it went up to 68%, and the current numbers are over 90% of malignancies in the oropharynx are related to HPV in Sweden. So this is what I like to describe an epidemic of virally induced malignancy. The current standard treatment is concurrent chemo and radiation therapy, but it's associated with a very high morbidity, as I described. We need to find a way to de-intensify the treatment, and lots of options are being explored. Upfront surgery with robotics has shown some promising results, but treatment failures are emerging even in these HPV positive patients. Not all survive, and I'll go into some of the reasons why. HPV vaccine uptake in the United States is low. It's improving, but it's still not where we need it to be, because this vaccine is preventative to the high-risk HPV strains that are out there. There is no evidence that HPV vaccine will protect, against all HPV-associated head and neck cancers, because there are many, many strains. And we need to develop better biomarkers to predict the optimal therapy for this disease. One of the biomarkers that we've identified is actually the strain of HPV. So as you know, right now there are 9 strains in the commercially available HPV vaccines, but there are over 129 strains of HPV that occur in nature. So when we looked at the Cancer Genome Atlas head and neck squamous cell carcinoma data set, we found that there were, out of these 528 patients, a fair number that were HPV positive. And what we identified is that the overwhelming number was HPV 16, and that does indeed account for 92% of HPV-related malignancies, and that is in the vaccine. So definitely recommend the vaccine. However, HPV 33 was also identified, but what we saw is that HPV 33 actually had a dismal prognosis. It was even worse than HPV negative tumors, which were smoking and drinking related tumors. So that was curious to us. So we began to look into what are the causes for that. And this is a graphic representation showing at the top in blue HPV positive, HPV 16 positive tumors, which had a very high survival rate. The black shows HPV negative or smoking and drinking related head and neck tumors, which resulted in about a 50% survival rate. But as you can see, the HPV 33 was far worse than any of them. It was a small number, but certainly the trend was statistically significant. And then when you compared HPV 16 to HPV 33 malignancies, you were 5 times more likely to die of the malignancy than if you had an HPV 16 tumor. And that actually came out true in the multivariate analysis as well. It was more important than age, gender, stage, smoking status, and even P53 mutations. So it's a very potent biomarker of a very bad disease. In fact, as I mentioned before, you were more likely to die of this HPV-related malignancy than smoking and drinking-related tumors, twice as likely to die, and that held up in multivariate analysis as well. So this HPV 33, which isn't included in all of these vaccines, is a very aggressive marker of failure for HPV-positive disease. Now, what could be another reason why this happens? When you look at HPV 33 cancers, they have reduced infiltration of CD8 effector T cells. So HPV 16 has a higher proportion of CD8 effector cells, and you can see that HPV 33 is similar to smoking and drinking related tumors with regards to their microenvironment and immune response rates. This is a bit of a busy slide, but what I want to show you here is that CD8 T cell fraction, which is the effector T cells in the microenvironment, the higher levels you have, the better your survival. You can see near universal survival with a high rate of CD8 in the microenvironment. You also had a very high survival rate if you had low TGF-beta expression, because TGF-beta tends to result in a permissive microenvironment for tumor growth, and interferon gamma that was high resulted in better outcomes. So there's no question that the HPV positive, HPV 33 positive tumors had a worse outcome, and it was because of the immune microenvironment. What are some of the biomarkers then you may say for HPV in general, and how likely they are to respond? Really, it looks like in analyzing the data that the immune cell density in the tumor microenvironment determines how likely we are to cure an HPV positive tumor. So it makes sense. It's a virus, right? And it elicits an immune response. But really, what our analysis here showed that if you have a large percentage of B cells in the tumor microenvironment, you can see here near universal overall survival and disease-specific survival if you have a high B cell fraction in your microenvironment, and you can see highly statistically significant. If you had a high rate of CD8 effector T cells, again, you had very good survival rate. But, the T helper cells was not significant. Macrophage levels were not significant, nor were natural killer cells. So effector T cells and B cell fraction in HPV positive tumors were more likely to have a better outcome. And this also shows that B cell activation, looking at gene expression. So those tumors that had a high level of B cell activation had much better outcomes than those that had a low level of B cell activation, both for disease-specific survival and overall survival. So while a lot of work is being focused on CD8 T cells in the microenvironment and tumor infiltrating lymphocytes, B lymphocytes we feel are very important in predicting outcomes. In fact, when you look at B cell activation compared to CD8 cytotoxic and cytolytic T cells, as well as CD8 effector T cells, the best predictor is B cell activation, and that was highly significant in predicting overall survival and disease-specific survival. So we think this will be a very important biomarker. Finally, immunoglobulin J expression is related to B cell activation. And while this is very small, and certainly, don't expect you to be able to read all that, it just verifies the point that, a high degree of IgJ or a high rate of IgJ, immunoglobulin J, predicts much better outcomes in both disease-specific survival, overall survival, and progression-free survival in HPV positive tumors. And this can be measured with CXCL13 in the blood. And what CXCL13, it's associated with immunoglobulin J, and it causes tertiary lymphoid structures in these tumors. And when you measure the CXCL13 level, and you can do this in the blood, there is a predictor of outcome. So this may be a bloodborne biomarker that we can turn to in the future. But when you look at IgJ, CXCL13, HPV status, and the rest, IgJ actually is a much better, IgJ and CXCL13 are much better predictors of survival than other tumor infiltrating lymphocytes. So how does HPV cause malignancy? It's a very interesting virus in that the early genes, E6 and E7, actually work via two different mechanisms. E6 inactivates P53. So as you know, P53 is mutated in 85% of all malignancies, but it's not mutated in HPV positive tumors. It's actually wild type P53, but E6 attaches to it and degrades it. So that causes the loss of the tumor suppressor P53. So that essentially takes off the brakes, of tumor growth. Then E7 then binds to the retinoblastoma gene, and it actually allows the transcription factor E2F to cause DNA cell cycle activation and proliferation. So that puts on the gas. So the way to think of it is E6 takes off the brake, E7 puts on the gas, and gene transcription occurs. So it's a very efficient virus at causing transformation and cell replication. So the way that E6 causes P53 inactivation is really two mechanisms. The reason I'm telling you this is because we can exploit these in therapeutics. So E6 binds to P53, and it prevents ubiquination and proteasome degradation of P53. So it binds to it, it ubiquinates P53, and then the proteasome eliminates P53 from the cell. The other mechanism, though, is one that we've exploited, and that's where the P300 transcription factor prevents the acetylation and thus stabilization of P53. So the way it does that is in the P300 complex, HPV E6 binds to these domains, the CH1 domain and the CH3 domain, and as well as the C-terminus domain. And by doing that, it doesn't, allow for stabilization of P53 with acetylation. So the mechanism typically is P300 binds 4 separate P53 proteins and causes their acetylation, which stabilizes it. Now, what E6 does is it hijacks that and it prevents this acetylation, which then prevents P53 from being active. So what our colleagues, myself and my closest colleague, Dr. Quentin Pan, discovered is that by inhibiting this interaction, you could actually, even with an HPV infected cell, allow for P53 to be stabilized and reactivated in an infected cell. So, 2 different inhibitors were created, one at the CH1 domain and one at the CH3 domain. And the CH1 domain was actually found to be most effective. So there was a protein mimetic created, which bound at the CH1 domain. And you can see here that then allows P53 to be reactivated. And this here, the drug is called OM1. And that, what you can see here is if no treatment, the tumor grows really quickly in a xenograft model of head and neck cancer. But with this drug, the OM1 derivative, it works as well as cisplatin chemotherapy, at limiting tumor growth. And when you combine the two, you actually completely knock out tumor growth in xenograft mice. You can see here that with OM1, P53 is expressed and acetylated P53 goes way up. So P53, in essence, is reactivated by the use of this compound. What this shows, it's also a durable response. So this is a representative animal study where 4 different animals were treated after tumor volume achieved a cubic centimeter in size. And when you combined this CH1 mimetic with cisplatin, all 4 animals essentially had their tumors regress, go away, and not come back after release of the treatment. So these were in essence pathologic cures of these tumors using a combination of that novel therapy with cisplatin. It also works as effectively with radiation therapy. So these are 2 different HPV positive cell lines, one called SCC37, the other one SCC90. And what you can see in orange here is that OM1 and radiation therapy works as well as OM1 and chemotherapy. And clearly, as a single agent, it's effective, but it's much more effective in combination with either chemo or radiation. And this just shows that, again, this compound is even effective in cetuximab-resistant patient-derived model where it was as effective as chemotherapy alone. Now, I will disclose that this compound was licensed to a German biotech company, and there were compounds that were created. However, that company went bankrupt, and they never got to promote this into the clinical setting. And we actually have repurchased those patents, so there's nothing to disclose because we own those patents, and they have not been reissued to another company. What's very interesting, though, is when we looked at other compounds that could potentially fit into that CH1 pocket and cause a similar effect, what we found is a commonly available drug, which has been used for decades and is safe to decrease cholesterol, called fenofibrate, actually has the same effect. So this is repurposing, commercially available fenofibrate to recapitulate what was done with that protein peptide mimetic. So this just very rapidly shows that fenofibrate has the same outcome as that novel therapeutic that we described. So again, control mice revealed, pretty steady growth. Fenofibrate or cisplatin alone halved the growth rate after 25 days, but the combination of cisplatin and fenofibrate, really had a synergistic effect. And as you can see, it reactivated P53. You could see P53 reactivation in these cell lines. And there was a lot of tumor necrosis that was noted as well with the fenofibrate in these models. So we have actually written a clinical trial to begin using fenofibrate in these patients as a proof of concept. And this shows just a little bit more, with regards to in vitro studies showing that it's effective against UMSCC47, CASKI, as well as the UPMC or UPCI SCC90 HPV positive cell lines with a large number of apoptosis, or a large percentage of cells undergoing apoptosis. So in conclusion, what I'd like to leave you with is the understanding that HPV-related head and neck cancer is an emerging epidemic. Millions of patients are infected with this, and the longer those patients live, the more likely they are to develop this malignancy. And also, millions of new infections are occurring. So this, if you look at the rate of this malignancy between 1990 and 2022, it has gone up in incidence by 300%. Whereas it was a rare tumor that I would see in my practice in the 1990s, it is now the most common tumor that I see. Cure rates are good, but the toxicity of our current treatments are very high. And really new therapeutic approaches are needed. Biomarkers are needed to determine which HPV infections are going to be the favorable ones compared to those that are not going to be favorable. I do believe that B cell activation in the tumor microenvironment will be critical to using immunotherapy for these patients, and then novel therapeutics resulting in P53 reactivation, as I showed, offer much hope. So this is my hospital. It's the Seidman Cancer Center. It's a freestanding cancer hospital, part of University Hospitals Health System. And with that, I thank you for your attention, and I would be happy to answer any questions.